I'm Natalie. I'm one of the A&E ST3s. I'm taking a year out this year, so I will be around locuming for the next year as well, so I'll probably see you in the department. I've been asked to do a talk on paediatric history and examination. It's more of an introduction to each of these, so we'll start from here. So first of all, just want to talk about what's different in paediatric medicine versus adult medicine. And the first thing to say is that children are quite resilient. They do compensate up to a certain stage, so they can become very sick quite quickly, but they also respond to treatment very well. They generally want to play and they generally want to be outside playing. Third thing to say is that the team is very good in paediatrics, so all the paediatric nurses are very approachable, very experienced. If you have any concerns, please ask them. And before I send a child home, I generally ask them if they feel safe sending that child home. The paediatric team that we refer to, again, very approachable, and they'll answer any questions that you have. The range in paediatric goes from the neonatal period up until the adolescent period and 16 years of age. There's quite a lot of changes within the child during that time, so you have to adapt your examination to how old the child is. So then the neonatal period, generally the paediatric team will see 0 to 1 years of age. If you're experiencing paediatrics and want to see neonates, that's absolutely fine, but they will need a paediatric team review. Later into the infancy, again, examination tips will go on to, and then as the child gets older, it's important to remember that they can speak for themselves, and when you can get the history from the child themselves, I would prefer to do that and then corroborate with the parents as well. In other suspicions of non-accidental injury, it's important to talk to the child by themselves sometimes as well. You've got to remember that you've got more than one patient. The child is sitting in front of you, but you've also got to remember it's the parents that brought that child in. And if you don't address their concerns, they're going to be leaving the department, still questioning why they came in. So I've put there communication, because that's really key in the paediatrics. Okay, so just talking a little bit about history taking in paediatrics. The things, like any history taking, you have to think about what's happened, why it's happened, how long has it been there for, and what's been the natural history of what's happened. And it's very similar to a normal history taking. Particularly in paediatrics, you've got to think about, are they feeding normally, are they opening their bowels normally, and have they got wet nappies? And my magic number is 3 wet nappies in 24 hours, and are they eating and drinking about 50% of their normal? If it's less than that, then I would get one of your seniors to review, or I would ask the paediatric team to review. I'm going to go through a few different presentations that we have, and the things that I want to know. If you're coming to present to me, if you're coming to present to one of the seniors, what I would want to know. So one of our most common presentations is fever in the department. The main things I want to know is how many days has that fever been present for? Has there been a fever every single day? And the significance of that is that any fever for 5 or more days, you'd start thinking about Kawasaki disease. I want to know what the parents are doing at home, so what treatment they've received, have they seen the GP, have they been started on antibiotics already, and what other associated symptoms. The main thing I want to know is there a focus of fever? I want to know if they've got tonsillitis, if they're diarrhea and vomiting, and that might give us a little bit more clue of what's going on. I also want to know if there's any contact with anyone unwell, and that might be other family members at the school or other siblings, and have they had any travel history. As I said, we want to know where the fever is coming from. If there is a fever of unknown origin, again, that would be stimulate to think about, do I need to get a registrar to come and have a look at the child, and do I need to do some bloods or x-rays to have a look for where the focus is coming from, or speak to the paediatric team. This is an alert that's gone out, so measles is quite big at the moment, and this is one of the posters that's been developed by the East Midlands team, just to think about the most common presentation of measles. So if you've got a fever with coryzal symptoms, conjunctivitis and a cough, please think about measles, because we have it's on the rise at the moment. Second, other quite common presentation that we have are seizures. Please be sympathetic to parents. It's quite a scary moment for them. It's not very nice when a child has a seizure. And even if it happens within the department, we run the child to resus. So it is very scary for the parents, so please take it seriously. When you're taking history about a seizure, I want to know exactly what has happened. What was the child like before the seizure? How have they been on the run up to the seizure? Have they had a febrile illness, or have they been completely well and this came out of the blue? I want to know exactly what happened during the seizure. How long did it last for? Was there any tongue biting? Have they wet themselves? What did they look like? Did they go blue? And then I want to know what happened afterwards as well. Did they recover quickly? Was there a long postictal phase? Some parents, if they've had seizures before, they'll know that we like to see a video, and sometimes they'll give you a video that you can see, and you can see exactly what's happened. I also want to know, has this ever happened before, and do they have a family history of this? This is listed straight from our guidance, so there's a paediatric guideline on seizures, and we normally focus on simple seizures versus complex seizures. Generally, if a child has had a simple seizure and we know there's a clear history of fever, we'll be able to discharge that child with safety net planning. Again, please get a review by one of the ST3 or ST4s and above before discharging a child. If there's any features of complex seizure, we want to either have more investigation or admit the child for observation. So the things I want to know are, was it a prolonged seizure of more than 15 minutes? Was it a focal seizure, so one-sided? Was there any evidence of a CNS infection? So are we suspecting meningitis or encephalitis? And also if they've had recurrent seizure during the 24 hours or that febrile illness. Any of those features would normally require admission and someone to review. Another common presentation to the department is head injury. This is where I want to mention about non-accidental injuries. So any history of trauma, which goes for all traumatic injuries, wrist injuries, ankle injuries, I want to hear what's happened in the child's words if possible. So initially I would sit the child down, sit the parents down, and I'd direct my questioning towards the child and try and find out in their words exactly what happened. You can then corroborate the story with the adults and make sure that you're happy that the level of development is consistent with the level of injury that you see in front of you. Things that I want to know, I want to know where it happened, how it happened, what happened, and what time was it. And again, this goes on to head injury guidance and what children would require further intervention, so CT scanning to look for intracranial bleeds. So the things I specifically want to know are the time of injury, did they lose consciousness, how high have they fallen or what have they fallen onto, is it a concrete floor versus a carpeted floor? Has there been any vomiting since then? Have they had a seizure? Are the parents concerned that they're not their normal self? And all of those things would lead, if any of those things are positive, it would lead you to think that you would want to observe the child for a little bit longer or maybe CT them, but again that would require a senior review. The rest, those are sort of going through the most common presentations and what I would want to know in the presenting complaint, and then the rest of the paediatric history is similar to an adult history with some things added. So past medical history, are the parents concerned that they're not meeting any of their developmental milestones? They normally carry a red book on them when they come into A&E, so it might be useful to have a look at that. In terms of birth history, you want to know, were they born at term? Where were they born? Was there any complications at birth? Were they a normal vaginal delivery or an emergency C-section? And why was the reason of each one? And was there any neonatal complications? Again, the significance of this is that if they had a meconium aspiration, required intubating at birth, they may be more likely to get respiratory complications coming into the ED. Then it's normal, I'd want to know their drug history, allergies, and then going on to social history, I want to know who's at home with them, where do they live, are the parents together, are they divorced, are they in care, do they go with a childminder during the day, what sort of setup do they have at home, have they ever been known to social services and for what reason, are all their immunisations up to date, as I said again, measles on the rise at the moment, and are they at school and are they developing well at school. And then a normal systems inquiry in terms of, I normally go head to toe and talk about sort of vomiting, diarrhoea, cough, coryzal symptoms, as mentioned before. Going on to the examination, just a couple of simple differences between adults and paediatric examination. As we all know, so children have a bigger head, they've got fontanelles, which if they have a bulging fontanelle and a head injury is a bad sign. And they've got immature respiratory centres, so they generally breathe quicker than we would, and they have abnormal respiratory patterns compared to adults. They've got a short neck and a big tongue, quite floppy airways, so again, resuscitating a child, you resuscitate them in the neutral position. Less than 6 months of age, they're obligate nose breathers, so if they have blocked nose, it's more difficult for them to sort of breathe normally. They have respiratory muscles which tire quite easily, and they also have soft bendy bones, so they might not break but they will bend. Just talking about a few of the tips and tricks of examining a child. So I think it's really important initially, either before you examine a child or after you examine a child, you do the observations yourself. The nurses generally are quite busy, and it's just part of your examination to do the observations. While you're having a chat with the child and the adult, I would generally just look at the child, see if they're sitting comfortably, if they're breathing quite fast, and generally you can get a look at how well the child is just from looking at the end of the bed as you normally would of an adult. I would normally examine them wherever they're comfortable. Generally, they're an older child or an adolescent, they'll happily lie on the bed and they won't be crying, whereas a younger child might want to sit on mum and dad's lap, and that's absolutely fine. You can examine them in that position. I've put a full body check in the end. Generally, you go down to the nappy or you go down to underwear to examine the whole of the child, looking for bruises or any other injuries. I'll then look, listen, palpate, and also examine the ear, nose and throat system, generally in that order, also looking for lymphadenopathy in child as well. Just going on to a few of our guidance, so there's a very good paediatric ED section looking at our guidelines, and this is just a screenshot of our webpage. And then we've got the top 10 most popular guidelines, which are quite useful to know, and then all the acute paediatric guidelines as well. And then I've just got a few, so 7 paediatric pitfalls and things that you'll learn to love about the department. And the first thing is that you have to listen to the parent's concerns. It's generally the parent that's brought that child in, so please listen to what they are telling you. If they are concerned, then you should also be concerned, and if they go away without you addressing their concerns, they'll just come back again. So please listen to the parents. The nurses are very, very experienced, and as I said before, I'll often ask them before I send a child home and make sure they're happy. If the nurses tell you to do something or tell you not to do something, please listen to them, or then come and have a chat with one of your seniors as well, because they're generally right and know what they're talking about. If you don't know anything, just ask. Please ask everything that you need to know in paediatrics. We don't expect you to know anything in the first few weeks. Some of you may have done paediatrics before and some of you may not. So please just ask anything you have to, and no one will shout at you for not asking something, all right? Please don't skip the paediatric patients. They're there just as long as the adults are, and we generally say that if you jump in, you'll get more comfortable seeing paediatrics. If you start with adolescents and work your way down, everyone's completely happy with that. Please do your own observations if you've got a chance. If it's really, really busy and the nurses obviously, or the student nurses don't seem to be very busy, that's fine, you can ask them, but generally you're getting a lot better if you do your own paediatric observations. Investigations is something where paediatric and adult medicine differ. Generally all the adults will get bloods and cannulas on their way in. However, it's not standard to do bloods on paediatric, on the children when they come in. So if you're thinking you need to do bloods and x-rays, please either have a chat with the nurses or have a chat with one of the senior A&E doctors, because generally it's not a line investigation for children. And I've learned to love Baby Shark since I've been here. It's been quite a steep learning curve, but you'll hear it most days. And then one of the paediatric doctors online mentioned that paediatrics is a Marmite specialty, and if you don't try it, you don't know if you love it or hate it. And that's it.